The following audio is part of a certified educational activity titled Navigating Through New Guidelines for Acute Nonspecific Low Back Pain, the Role of Non-Pharmacologic Therapies. Access the entire activity and complete the post-test at www.peerview.com/AUM. Downloadable infographics are also available.
Hello, this is Dr. Melissa Weimer from St. Peter's Health Partners in Albany, New York. Welcome to this infographic-based educational activity focused on the non-pharmacologic management of acute nonspecific low back pain. When we think about low back pain, it's important to recognize that it's a very common condition and is associated with more global disability than any other condition. And we've seen that the disability of this condition is actually increasing over time. From 1990 to 2010, we saw an increase from 58.2 million disability-adjusted life years to 83 million in 2010. And out of all of the 291 conditions that have been studied in the global burden of disease, we saw that low back pain was highest in terms of disability and sixth in terms of overall burden of disability. We also see that prevalence and burden increases with age, but we also know that it can affect people of all ages and is a leading contributor of disease burden worldwide. When we think about back pain, it's important to characterize what type of back pain we're discussing. And we characterize this based on the length of time that the person has had the pain. Acute back pain typically persists less than 4 weeks. Subacute back pain typically lasts anywhere from 4 to 12 weeks. And chronic back pain persists greater than 12 weeks. And what we see is that acute back pain is one of the most common reasons many adults see a primary care physician. So there are many reasons why we would want to know more about how to better treat low back pain. And one reason is that since the 1990s, we've seen an increase in the prescription of opioids. Unfortunately, paralleling that increase in prescription of opioids for conditions such as back pain, we've seen that deaths due to opioids have also increased, as well as people seeking admission for opioid use disorder. We also know that when a patient is prescribed opioids, there are many potentials for harms, including the development of an opioid use disorder, which could cause them to misuse them or potentially transition to heroin in the future. We recognize that about 80% of people who use heroin were first exposed to prescription opioids. So if we can prevent people from being exposed to opioids for conditions such as back pain, it's important that we find a way to do that. Opioids have many side effects. They include tolerance, meaning that the medication is not as effective as when it was initially prescribed. Physical dependence occurs over time, and physical dependence can actually occur in less than 2 weeks of an opioid prescribed at a high enough dose. Additionally, you can find that opioids for some people will actually increase sensitivity to pain. Other side effects such as constipation, nausea, vomiting, dry mouth, sleepiness, dizziness, confusion, and depression can also occur. We also see that in men, there can be effects on testosterone, causing a lower sex drive, energy, and strength. And this is really seen when opioids are taken for a prolonged period of time. Although other side effects such as allergy are relatively rare, so the rationale for shifting away from opioids and towards other non-pharmacologic effects is because most acute nonspecific low back pain actually resolves over time without any treatment. And we see that the spontaneous recovery rate is more than 50 to 75% at 4 weeks and more than 90% at 6 weeks. Therefore, if we can shift towards using more non-pharmacologic treatments as first-line treatment, then we can potentially prevent some of the harms that have been seen by prescribing opioids. Because of this, an evidence review was done in 2017 by AHRQ's Pacific Northwest Evidence-Based Practice Center. They evaluated outcomes including reduction or elimination of low back pain, improvement in back-specific and overall function, improvement in health-related quality of life, reduction in work disability, return to work, global improvement, number of back pain episodes or time between episodes, patient satisfaction, and adverse effects. Based on this evidence review, a clinical guideline was developed by the American College of Physicians Clinical Guidelines Committee, and they graded evidence as either strong or weak based on the quality of the evidence from the evidence review. We're going to discuss the evidence that was collected from this evidence review and then the subsequent clinical guidelines. So the first non-pharmacologic therapy that was reviewed was the use of superficial heat. Superficial heat was compared to placebo, showing that there was moderate quality evidence that the use of a heat wrap moderately improved pain relief at 5 days and function or disability at 4 days compared to placebo. When compared to exercise, there was low quality evidence, and this showed some improvements for pain and disability, though there was another study showing no clear differences between pain relief and function. And then finally, a study was done comparing superficial heat to acetaminophen or ibuprofen, and this showed low quality evidence that the superficial heat was more effective for pain relief and improved function. So altogether, the data was summed up as showing moderate quality evidence to suggest that superficial heat, with and without combination of other treatments, is moderately effective for treating the pain associated with acute low back pain and function. And this evidence was actually new from the 2007 evidence review. The second non-pharmacologic therapy that was assessed was the use of massage. And in general, when looking at massage compared to other therapies, they showed that there was low quality evidence to suggest that it was effective for small to moderate improvements in pain and function based on comparison to sham therapy, other types of interventions such as manipulation, exercise therapy, relaxation therapy, acupuncture and physiotherapy, and usual care. Next, acupuncture was assessed for a non-pharmacologic therapy for acute low back pain. The evidence was low quality, showing that acupuncture resulted in small decreases in pain intensity compared with sham acupuncture with non-penetrating needles, but there was no clear effects on function. There was also low quality evidence showing that acupuncture slightly increased the likelihood of overall improvement compared with non-steroidal medicines. When looking at spinal manipulation was compared to sham therapy, inert treatment, and active treatment, and altogether there were some mixed results showing low quality evidence suggesting that spinal manipulation had small effects on improving function compared with sham manipulation, but not inert treatment. When low-level laser therapy was investigated, it showed low quality evidence that a combination of the laser therapy and non-steroidals largely decreased pain intensity and resulted in a moderate improvement in function compared with sham laser therapy plus non-steroidals in patients with acute or subacute low back pain. Exercise was also reviewed and showed low quality evidence of no difference between exercise therapy and usual care for pain or function. There were several additional trials that did show other inconsistent results. And when they looked at different exercise regimens in greater than 20 head-to-head randomized controlled trials, they saw no differences between those different exercise regimens. The last form of non-pharmacologic therapy that showed some evidence for its use was lumbar support. This showed low quality evidence that there was no difference in pain or function between lumbar support added to an educational program compared with an educational program alone or other active interventions in patients with acute or subacute low back pain. Multiple other types of non-pharmacologic therapies were reviewed in the evidence review, but evidence was insufficient to determine their effectiveness for acute low back pain. These included transcutaneous electrical nerve stimulation, also known as a TENS unit, electrical muscle stimulation, inferential therapy, shortwave diathermy, traction, superficial cold, motor control exercise, Pilates, Tai Chi, yoga, psychological therapies, multidisciplinary rehabilitation, ultrasound, and taking. Now we're going to discuss how to integrate these new guidelines for the treatment of acute low back pain into clinical practice. Based on the evidence review that we just discussed, the ACP Clinical Guidelines Committee developed the following guideline for the treatment of acute low back pain. Their recommendation is that given that most patients with acute or subacute low back pain improve over time regardless of treatment, clinicians and patients should select non-pharmacologic treatment with superficial heat that has moderate quality evidence, massage, acupuncture, or spinal manipulation, all of which have low quality evidence. If pharmacologic treatment is desired, they recommend that clinicians and patients should select non-steroidal medications or skeletal muscle relaxants, and both of these have moderate quality evidence. To review, when you're thinking about a non-pharmacologic therapy, what you would suggest to a patient is if you're looking for improved pain and function, you may be able to achieve this with superficial heat through a heat wrap or massage, and both of these have small to moderate effects. When looking more for improved pain, you may find that acupuncture specifically can help improve pain. And then spinal manipulation does have a small effect on improving function. So these 4 different types of therapies are something that you might suggest to a patient. When evaluating the harms of the non-pharmacologic therapies, this was assessed across the interventions and no serious harms were noted, although the reporting of harms was suboptimal in most of the studies. Superficial heat was only associated with increased risk of skin flushing, massage and spinal manipulation were associated with muscle soreness, and acupuncture needles were associated with pain and bleeding. So let's talk for a minute about the different pharmacologic therapy that you might discuss with a patient for the treatment of acute low back pain. 2 of the recommended therapies are non-steroidal medications or skeletal muscle relaxers. The choice between one of the other should be individualized based on the patient's preference and their likely individual medication risk profile. If non-steroidal medications are preferred treatment for the patient, you can let them know that there were small improvements in both pain intensity and function as seen in the evidence review. There were associated gastrointestinal and renal risks that were seen, and you would want to assess these risks before prescribing the medication. COX-2 selective NSAIDs were not assessed for improvements in pain or function, though these might be alternatives if you're concerned about risks of adverse effects. Similarly, skeletal muscle relaxers did show small improvements in pain relief with moderate quality evidence, though there was no evidence for effects on function. And they were associated with central nervous system adverse effects such as confusion and sedation. It's important that you're communicating with your patients about the typical prognosis of acute low back pain. It's important to inform them that acute low back pain generally has a favorable prognosis with or without sciatica, including a high likelihood for substantial improvement in the first month. It's important to provide patients with evidence-based information with regard to their expected course, advising them to remain active as tolerated, discouraging bed rest, and providing them information about effective self-care options. Using a shared decision-making approach may be most helpful to help them decide on an appropriate treatment based on their preferences, availability, harms, and costs. If a patient expects to be treated with an opioid therapy, it would be important to first recognize risks associated with this type of treatment. There are very specific risk factors for the treatment of low back pain with opioid pain relievers, and you would want to look at those with your individual patient. Risk factors that are well described in the literature include patients receiving medications from multiple providers and pharmacies, patients having mental illness or a history of substance use disorder or family history of substance use disorder, patients who already have existing high physical dependence who might be taking high daily doses of prescription pain relievers, those who have low income or low access to health care. Other risk factors are also patients who are younger and patients who have history of sexual abuse or trauma. If patients expect to be treated with opioids, it would be important to educate them about the risks of opioid use disorder, physical dependence, and other side effects that we mentioned. It would also be important to inform patients that back pain is common and that they're likely to spontaneously recover and not be exposed to the potential risks of opioids. Inform the patient about the benefits and recommendations for non-pharmacologic therapy, and as always, communicate in a non-judgmental. In conclusion, we know that acute low back pain is a common problem. There are recent guidelines that recommend using non-pharmacologic therapies for acute low back pain. If pharmacologic treatment is desired, considering a non-steroidal medication or a spinal muscle relaxant is recommended over a medication such as an opioid. Treatment decisions must be individualized and based on patient preference and the risk versus benefit profile of the therapy. Patient education regarding the favorable prognosis of acute low back pain, the risks of opioids, and the benefits of non-pharmacologic therapy are critical.
This activity has been jointly provided by Penn State College of Medicine and PVI, Peerview Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at www.peerview.com/AUM. This activity is supported by an educational grant from Pfizer.